A very good afternoon to everyone. I, Samriddhi Pednekar from the marketing team of Hetero Healthcare Main Division, welcomes all esteemed doctors to this informative webinar. Today we are here to shed light on the topic influenza and its prevention and the role of molecule oseltamivir in pediatrics. And to discuss this, I would like to invite our first speaker, Dr. Pramod Jog, one of the eminent pediatrician, Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IAP 2016. So, very good afternoon, sir. Thank you for joining us.
Good afternoon.
Also, I would like to invite our second speaker and very renowned pediatrician from Kolhapur, Dr. Sainath Pawar, MBBS, MD Pediatrics, consulting pediatrician, pediatric pulmonologist, consulting allergy asthma specialist, and President, Kolhapur Academy of Pediatrics 2024. So, good afternoon, sir. Thank you for joining us. Now, I would like to hand over the session to Dr. Jog, and I sincerely extend my thanks to all the doctors who are participating here. And without any further delays, I hand over the session to Dr. Pramod. Thank you, sir.
Thank you. I will just share the screen. I hope the screen is visible.
Yes, sir.
Yes.
Yes, and I think it is. Yeah. Am I audible also?
Yes, sir.
Thank you. So, we will be discussing the topic of pediatric perspectives of flu today. Actually, it's a very interesting topic, and all of us are surrounded by clouds and rainy season. And as everybody knows, in India, the rainy season is the main season for influenza. And for last so many years after the pandemic in 2009, we have been discussing influenza every year. Whenever a new strain of the vaccine comes, we discuss it. Whenever the monsoon begins, we discuss it. And if you see, my name has been put in the form of the influenza virus, which includes the nomenclature, the origin, the place from where the virus originates, and so on. And we will see further details as we progress in the talk. And we will start with a case where there is a 3-year-old boy coming to the OPD with fever, cold, cough, and progressive breathlessness over 3 days. And the child is tachypneic with hypoxia at room air. And you can see that the X-ray is showing ARDS. The progression has been very rapid. So the child has been admitted to PICU. The child has been ventilated. He has received oseltamivir and supportive therapy. And after the throat swab was sent, the result says that it is H1N1 positive. The child was ventilated for 3 days, and then the child was all right. Okay. Now here, the question is whether this child could have been given early oseltamivir before the child got admitted, because all of us have heard that treatment with oseltamivir given in the first 48 hours of influenza works the best. Okay. So whenever you have the initial presentation of this case, where the child was absolutely healthy, then presented with cough, cold, and fever, and progressed over 3 days, whether the treating physician have prevented this progression, that is the main question. And whether every patient of cough, cold, and fever during this particular flu season should be given oseltamivir upfront. So we are going to discuss some of these aspects, and that's why we must first know as to what are the areas where there is little bit of confusion. As it is related to flu, I have put it as confusion. So whether it is bacterial or viral, whether viral infection is because of rhinovirus, adenovirus, or influenza. If it is influenza, what is the type? And then, if at all, I am strongly suspecting influenza, whether I should start oseltamivir upfront, and whether I should give every patient antiviral to play safe. Now, all these questions always come to our mind. And the first question, whether the child has bacterial or viral infection, is something which is actually to be answered by all of us before we start the therapy. So we all know that whenever a child gets viral infection, more than one system is involved. So the child will have runny nose, the child will have cough, the child will have fever, red eye, the child might have rash, the child might have diarrhea. So more than a system is involved that is viral. While in bacterial infection, usually it is only one system involved. So if it is respiratory system, then it will be affection of only say the tonsils in the form of follicular tonsillitis. If it involves within the respiratory system, the lungs, then it would be pneumonia, but it will be localized to that system itself. Okay. In between the fever episodes, for example, if he gets fever at 12, he receives paracetamol and again starts getting fever at 6, then between 12 and 6 in the afternoon, the child will be absolutely normal. That is called as interfebrile period. That is very classical of viral infections. While in case of bacterial infections, even if the fever goes down, mother says that the child is not appearing really well. He is not his real usual self. So a child with bacterial infection usually will continue to be little bit dull. He will not play, he will not eat, he will not smile. So that is bacterial infection. And we must remember that the viruses which affect the respiratory system, like the rhinovirus or the influenza virus or the parainfluenza, RSV, adenovirus, all these, they have lot many similarities. And I always jokingly say that even Rajnikant cannot differentiate these different viruses given a choice. The point is that whenever a rhinovirus affects the respiratory system, it will mainly affect the nose. There will be sneezing, cold, and the child won't be that bad. While, as we have learned over the last 1 or 2 years, adenovirus is the one which not only involves the respiratory system but other systems also. The child might have mesenteric lymphadenitis. The child might have hemorrhagic cystitis, and so on and so forth. Influenza is a bit different virus. And as we all know, it's a virus which is the father of all the influenza like illnesses. Okay. So the child will come to us with headache, the child will have myalgia, and the child will have weakness. So when these three come together in an influenza season in monsoon, we have to be very careful. And these are the children where you can always start oseltamivir upfront, because even WHO has given a guideline that whenever there is influenza season, whenever there is epidemic around, then at that time, if you find that the clinical presentation is very, very strongly suggestive of influenza, one should not wait. And that is simply because oseltamivir works best when it is given in the first 48 hours. Okay. We'll be seeing the types of influenza, whether it's type A, B, or C, whether it is possible to differentiate. And we will also discuss as to whether every patient can be given antiviral. Now, whether it is possible to attribute cold, cough, and fever to a particular virus. As I was just trying to tell you, the true influenza is because of influenza virus A or influenza virus B. Remember, virus C infections in influenza are much milder. And whether it is influenza-like illness, which is caused by a variety of other organisms, which are often called as flu. So, even parents many times come and say, like the other day, I remember one small little girl came to the OPD and she had a doll in her hand and she was saying to the doll, telling the doll, don't worry, it is viral, it is flu, it is viral, it is flu. So even small children know that, it is something like, a viral infection. And one should be aware that true influenza and influenza-like illness, both are very, very difficult to be differentiated. And we must know as to how common it is. So globally, the annual attack rate of influenza is about 5 to 10% in adults and 20 to 30% in children. And this virus is transmitted, as we all know, by the respiratory aerosols. Okay. And within 18 to 72 hours of incubation period, the person in front gets infected. And this shading of the virus from person to person, basically, it occurs through sneezing, coughing, talking, and touching, or the contaminated objects. These are called as the fomites. And in children, the shedding goes on longer. And in adults, it is for up to 7 days. And if the person is immunocompromised or there is severe illness, then the shedding continues for a long time. But the body fluids and the hand-to-hand contact are the ones which are responsible for almost 70% of the influenza transmission, while the airborne transmission is 30%. Okay. And a swine flu infected person can shed the virus 24 hours before the symptoms begin, up to 7 days later. So when the child starts having the symptoms, already the child is infective. Okay. And then there are many parents who would like us to tell them about the different, influenza viruses. So many patients to me, they come from the IT sector. This is the information technology sector. However, I call them jokingly as inquisitive and troublesome parents. And they are the ones who usually bring their own laptops. They come in Bermuda pants, and then they will start asking one question after other about the different types of viruses. And I have to be very, very clear as to the discovery of the influenza virus, which took place in 1931 in the pigs, then in human beings in 1933, and then the classification of these various viruses, and that there are three types of viruses, A, B, and C. Okay, and they will also probably ask you about the drift and the shift. So whenever there is a minor antigenic variation, okay, in the antigens outside in the virus, then usually it produces what is a drift. And that is why every year, there is a slight change in the structure of the virus because of the change in the amino acid sequence. However, when there is a major change in the structure of the virus, then it is called as antigenic shift. Okay, this is the one which occurs usually when there is a pandemic. So in 2009 it was the major change, that was the antigenic shift. However, type B is the one which is restricted only to the human beings, and it produces only local epidemics. And type C, as I told you, produces simple common cold like illness. So let us go a bit deeper into influenza A virus, which is classified into subtypes based on the antibody responses to the glycoproteins on its outer side. See, influenza virus has two glycoproteins outside, hemagglutinin and neuraminidase. And these different types of HA and NA with different permutations and combinations, they will produce different influenza viruses, nomenclature. Okay. So for example, it could be H1N1, H2N2, H3N3, it could be H5N1, anything. So remember that only H1, 2, and 3 and N1 and 2 are found in the human beings, while the numbers which are of higher order, like 5, 7, they are the ones which are usually found in the birds and the animals. Okay. And this is the beautiful influenza virus, which is orthomyxovirus, and it has hemagglutinin and neuraminidase on the outer side. And we can see that in the center, there are RNA proteins, which are coiled structures. And this particular virus is a very, very naughty virus. Why naughty? Because this RNA always changes the structure every year. And viruses like COVID, for example, they change structure so many times that we were finally, fed up of having newer and newer vaccines against COVID also. So remember, RNA viruses always change their structure. About influenza B virus, remember that it is the only in human beings. There are no subtypes, and it causes less severe disease as compared to influenza A. And influenza B mutates at a rate 2 to 3 times lower than type A, and it is common in children between 5 to 17 years, and it is showing reduced rate of antigenic change. Okay. Now, HA and NA, what is the exact role? See, the hemagglutinin from the virus usually is useful for attachment to the respiratory mucosa, while neuraminidase is the one wherein it is responsible for transmission of the RNA virus, the particles from the virus to the respiratory epithelium, and propagation of the virus. So when you give neuraminidase inhibitors like oseltamivir, the transmission of the RNA to other cells stops. It is halted, and that is why the progression of the disease stops. That's why the severity of the disease remains at a lower level. Now, where do the new hemagglutinin and neuraminidase they come from? You can see that there is a bird and a pig in this particular picture, and pig is the one where there is a mixture of the avian, that means the viruses from the birds and the viruses from the human beings. You can see that there are 18 types of hemagglutinins and 11 types of neuraminidase, and all of them they circulate in the birds. And in the pigs, as I'm just going to show you one picture, there is mixing of these different strains, so that the pig acts as a mixing vessel, something like a bhel which has murmura and save and papdi and some vegetables and so many things. So the pig's body is a mixing vessel wherein the new virus is produced. As I was just telling you in the beginning, when I showed you my name, I will just tell you as to what is the naming ceremony of the viruses like. So there is a type of the flu virus like H1N1 or H3N2. Then there is a geographic location where it come from. For example, California or somewhere. The strain number, the year of isolation as to whether it was isolated in 2009 or 2011. So for example, it would be type A, Victoria, 361, 2011, and then H3N2. So that is the way in which the viruses are named so that people know as to which virus we are speaking about. And as I told you, this particular antigenic drift indicates the minor change, and antigenic shift indicates a totally gross change, a major change. So, for example, if Pramod becomes Vinod, it's a small change. But then, in case if Pramod changes to, say, Sainath, then it's a major change. So, it's an antigenic shift, total change in the structure. And the drift depends on the little change in the amino acid sequence, while the shift is the one where there is a total change in H1 and N1. And this is the one that I was speaking about, that the bird flu and the human flu, the viruses. So the pigs may harbor different viruses simultaneously from birds and human beings. And then from the pigs, the new viral strain is transmitted to the human beings through inhalation of the viral particles by the human beings. Suppose if there are human beings who are staying near the piggery, then at that time, the human beings will inhale that. And then the human being will start transmitting from each others. And then they will have the various symptoms like fever, cough, breathing difficulty, loss of appetite, and so on and so forth. Now, what happened in 2009 was a novel flu strain which evolved, which combined the genes from the human beings, the pig, and the bird flu. And likewise, there have been 4 major global pandemics. One was in 1918, other one in 1957, one in 1968, and the one in 2009 that we have all witnessed. Okay. Now, as I told you, influenza B pandemics do not occur. And there have been no shifts recorded with influenza B, and there are no animal reservoirs known. And as I told you, the rainy season is the one where there is definite peaking of the influenza viruses. And between June to August in the north, west, and east, and from October to December in south. Remember, out of H1N1 and H3N2, it has been found recently that H3N2 is the one which is responsible for severe illnesses. And we must remember that the vaccine contains H1N1 as well as H3N2. And it is necessary that we give this vaccine to children between 6 months and 5 years, and later on to those who are at a higher risk of getting influenza. Now, as I told you, influenza presents with different clinical manifestations like abrupt onset. A child coming to the OPD with fever and chills and respiratory symptoms like cold and cough, but more of the systemic symptoms. So the child will have high fever, muscle pain, malaise, headache. So when an older child is being lifted by the parents and brought to the clinic, it means that there is something wrong, which is a systemic illness. A child with rhinovirus will have only sneezing and little bit of fever and runny nose. But then a child with influenza particularly will have upper respiratory symptoms, might have even croup-like symptoms when there is a change of voice with stridor, or there could be progression to lower respiratory tract, which I told you in the first case, where the child suddenly became breathless. Okay, and being a viral illness, it could have another symptom involved like the GI symptoms. Okay, and the febrile illness is usually 2 to 4 days, but the cough persists longer and it has a high transmissibility. So by the time the first one recovers, the second one is also sick. Then the third one, like that, the family or the close contacts get involved. And remember that when symptoms are out of proportion to the duration of illness, then you must always suspect influenza. Okay. And between 40 and 85% of infections with influenza result in clinical illness depending on age and the pre-existing immunity. So you can see that quite a few patients, they become clinical and very few remain subclinical. And that is why you must have high index of suspicion. And in case of neonates and infants and premature babies, you also have to be very careful, because sometimes they may present in a different manner. Remember that the earlier the age of the child, the burden of the disease, the fatalities are very, very high. And that is why we usually want to protect the children, because children are the one who transmit the disease from them to the adults. During COVID pandemic, we saw that the disease was transmitted from the adults to the children. But influenza is a disease which is mainly transmitted from children to the adults, and that is why controlling the infection in children by giving vaccine as well as controlling it by giving antivirals in the beginning of illness is very, very important. Okay. And what are the complications which are encountered in pediatric influenza? Respiratory complications by far are the most common. So in 10 to 50% children, we have otitis media, and there is typical time of onset 1 to 4 days after the onset of influenza symptoms. There could be pneumonia, which is viral pneumonia, and Staphylococcus aureus or Streptococcus pneumoniae. They will complicate it themselves, in a child with influenza. And it is said that almost 25% of children who have influenza can have associated pneumonias which are bacterial in nature. And that is why, in addition to the pneumococcal vaccine, influenza vaccine together will protect the child to a greater extent. This is very important. In fact, in case of influenza, it has to be remembered that the co-infection is very, very common. And that is why we have seen even during COVID plus influenza, we had the co-infection. COVID with bacterial pneumonia, it's a co-infection. And we have to remember that many times the viruses, they set the stage for bacterial infection to occur. In addition, exacerbation of the chronic pulmonary conditions like asthma, particularly beyond 2 years, is very, very important. And respiratory failure could occur in about 5%, and there could be acute laryngotracheal bronchitis. There could be toxic shock syndrome. There could be myocarditis. And very important are the neurologic complications, where there could be a simple febrile convulsion or influenza-associated encephalopathy due to cytokine dysregulation, or acute necrotizing encephalitis, or Guillain-Barré syndrome, or even aseptic meningitis. And one has to be very, very much aware of these neurological symptoms. Many children come to us with influenza B between the age of 6 to 9 years, the boys, where there is bilateral gastrocnemius and soleus involvement. They complain of severe bilateral calf muscle pain and inability to walk, and they do have rhabdomyolysis. Hepatic involvement can lead to what is called as Rye syndrome, and particularly a child with influenza B, if he is given aspirin, salicylates, then he might land up into liver failure. So just remember the alphabet A, so that the child has acute otitis media, acute respiratory infections, absenteeism from the work or the school, and antibiotic abuse. Just as our colleagues are unable to differentiate viral from bacterial, they many times land up giving, antibiotics like amoxicillin or azithromycin. And that's the reason why there is antibiotic abuse, as a part of therapy in influenza. And we will have to see as to when to suspect H1N1 flu and what is influenza-like illness. So the CDC has clearly told that if there is a contact within 7 days with a person who has a confirmed case of H1N1, then that is clear-cut case of influenza. And influenza-like illness is also defined whether there is either acute respiratory illness with fever and cough and onset in the last 10 days, then that is influenza-like illness. And in case if there is history of fever, cough, along with hospitalization, then that is called as severe acute respiratory infection, also known as SARI. So remember these two terms. And the CDC, WHO, and the Infectious Disease Society of America, they recommend that diagnosing the influenza clinically and performing the testing only in the conditions where the patient is hospitalized or the one who unfortunately dies because of an influenza-like illness. So there, it is essential that you prove that this particular person or the child has definite influenza, either H1N1 or H3N2. And there are certain high-risk groups who are likely to have severe presentation. And for the sake of convenience, I have started all these conditions with the alphabet C. So if there is a congenital or acquired immunodeficiency, or a cardiac, pulmonary, hematologic, renal, liver, or diabetic, or chronic aspirin therapy, or compromise due to neurologic disease, or corticosteroid therapy for asthma, or people who are basically obese. So these are the people who are to be always rather observed because they are high risk categories. And of course, the ones who are elderly, they are also the ones at a higher risk. So if you come across any of these, because in a family it is possible that the child has influenza and the grandfather is asthmatic, the mother is say pregnant, the father is likely to be diabetic. So any person in the family can have some high risk condition, and that is why we have to be very careful for these people. Okay. And then the grading of the severity of influenza has been done in children. So there are three categories: category A, B, and C. In category A, in general, the disease is mild with mild fever, cough, and there is a bit of body ache or a headache, vomiting or diarrhea. The child should be monitored. The child should not mix up with the public and the high risk family members, but there is no need for H1N1 testing. In category B, the fever is of higher grade and there is severe sore throat, or these people who have high risk conditions. And in category C, it is breathlessness, chest pain, drowsiness, fall in blood pressure, sputum with blood, and bluish discoloration of nails, that is cyanosis, and worsening of the underlying chronic condition. So if the child is of that grade severity, then that is category C. Okay. So this is very important that you understand, because these red flag signs are the ones which will guide us and which will tell us that we need to give oseltamivir. So if the child is excessively sleepy, if the child has high persistent fever, not feeding well, getting convulsions, shortness of breath, difficulty in breathing, obviously the child needs hospitalization, testing for H1N1, and treatment with oseltamivir. This is extremely important because when the child goes home from the OPD in the first 1 or 2 days after receiving paracetamol, then the parents must be told that in case if you find these 4, 5, 6 things in the child, please report to us because we might have to put him on the antivirals. Okay. And then there are some investigations. The most common is, of course, the RT-PCR, which is done by the nasopharyngeal swab. And we must know the management as per the staging. So initiating the treatment as soon as possible after the onset of influenza-like symptoms is very important. And the CDC has clearly recommended antiviral prophylaxis for people who have had close contact with an infected person during the infectious period. I told you that the infectious period begins 24 hours before the symptoms begin. And that is why treatment should not be delayed until the results of the diagnostic test are available, because the first 48 hours are extremely critical. And that's why the initial treatment involves bed rest, fluids, cough suppressants, antibiotics, and the treatment should not wait for the lab confirmation. As I told you, because the most effective results are only when the treatment is started before 48 hours of onset of the disease. And there are some important antivirals which our colleagues must be knowing. And neuraminidase inhibitors, which I mentioned, they are the ones which block the viral neuraminidase enzyme, which is critical in the release of the virions from the infected host cells. And they are the drugs which are active against influenza A and B, for example, oseltamivir and zanamivir. Zanamivir is a powder that is inhaled and approved for treatment of flu in people beyond 7 years. And it is not recommended for people with breathing problems like asthma or COPD. A detailed discussion about oseltamivir is important because that is the only antiviral which is available, with us today. So it was approved for medical use in the US in 1999. It was the first neuraminidase inhibitor available by mouth, and it's a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And remember, oseltamivir is the prodrug which is converted to the active form, oseltamivir carboxylate, in the liver. It inhibits the release of the virions from the host cell and it prevents further spread of infection. Now, what is the mechanism of action? Remember, as neuraminidase is responsible for cleaving the sialic and the neuraminic acid, it is one of the key factors responsible for influenza virions entrance and the exit from the host cell. So inhibiting the neuraminidase enzyme effectively halts the influenza virions ability to spread to the new human cells. And that is why the spread of the disease within the body is halted, and that is why the child does not get serious. Okay. And we should know whether it really helps in influenza. The answer is yes, because it reduces the risk of otitis media. There is 37% reduced risk for low respiratory complications. There is reduction in the duration of the sleep, hospitalization, and lower risk of severe complications requiring mechanical ventilation, and even later initiation of therapy is beneficial. And what are the recommended doses of oseltamivir in children? Particularly in infancy, the dosages are different. The treatment, remember, is given for 5 days. So under the age of 3 months, it is 1 ml, that is 12 milligrams twice daily. Between 3 to 5 months, it is 20 milligrams, that is 1.6 ml twice daily. And between 5 and 11 months, it is 25 milligrams twice daily. Remember that less than 15 kg, the dose is 30 milligrams twice daily, and that is available as either syrup, or conveniently we have these days a capsule of 30 milligrams. So you can give one capsule in the morning, one in the evening. Between 15 and 23 kg, it is 45 milligrams twice daily. 23 to 40 kg, it is 60 milligrams. That is equivalent to 2 capsules in the morning, 2 in the evening. And above 40, it is like 75 mg twice daily, the adult dose. Now, prophylaxis is recommended particularly in certain conditions. Remember that routine antiviral chemoprophylaxis is not recommended. But if the woman is there who is pregnant, and there is a person who is at a high risk of complications, which I told you all those conditions starting with C, and healthcare providers and emergency medical personnel like you and me who are not vaccinated, then they are the ones who should receive chemoprophylaxis. Remember, chemoprophylaxis is for 10 days. And below 3 months, it is not recommended. But between 3 months to 12 months, and later on about 12 months, it is to be given in the dosages which are same, but given once daily. Okay. So therapy with oseltamivir is for 5 days. Prophylaxis is for 10 days. Whether oseltamivir is tolerated well? Yes, in general, it's tolerated well. There is only nausea and vomiting, which are the most frequently reported adverse events. Very, very rarely people can have some anaphylactic reaction, and one should be aware of this side effect. And remember that whenever you are suspecting flu in a flu season, or you are in contact with a person who has been proved laboratory-wise with H1N1, then you can use oseltamivir on suspicion. Okay, use it before 48 hours, and whether you use it or no, it all depends on the season, the suspicion, and the high risk condition of the person. Remember that Alexander Fleming had warned about penicillin resistance, and similar thing one should be aware in case of oseltamivir, that it should not be used indiscriminately. It should be used at the right time, but better late than never. And you have to be aware of the limitations of this drug, including the adverse effects. And unless there are specific risk factors, there is no role for chemoprophylaxis. So what are the recommendations for use of oseltamivir? As I told you, category A, we have only symptomatic treatment, and we have to avoid salicylates, only give paracetamol, and the person or the child should be reassessed. Category B requires home isolation, full course of oseltamivir, and if needed, broad spectrum antibiotics. And in category C, obviously they require oxygen, maintenance of airway, breathing, circulation, hydration, electrolyte imbalance, nutrition, and then mechanical ventilation if required, as we saw in the first case, and then broad spectrum antibiotics if required, but full course of oseltamivir. So remember that this influenza virus is a fast and a furious virus. The onset is abrupt, the transmissibility is high, the progression is very rapid. The child may develop ARDS very fast, and as in my residence terms, the child may get a vertical discharge very fast if not treated properly. And oseltamivir has to be started very early. Okay. In addition to prevention by giving the vaccine, one must remember that there are certain etiquettes which are called as cough and sneezing etiquettes. So one should always cough in the handkerchief. One should cough in the elbow. One should always wash the hands. One should avoid shake hands, but do namaste as our Indian tradition. And it's very important that you follow all these hasta sutras. These are the certain things which are connected with the hygiene related to cough, also known as cough etiquettes. So with that, I'm just saluting you with only namaste, because that is the way we have to greet a person in our Indian tradition, and avoid shake hands, because that will avoid the transmission with the fomites. Okay, so with that, I will stop sharing the screen for a while, and along with my colleague Dr. Sainath, we will discuss certain issues which we face in the day-to-day practice. So I'm sure, Dr. Sainath, you have many patients of influenza coming these days, because the days are full of dengue, chikungunya, we have typhoid, we have gastroenteritis, flu, and so on, so forth. The
Yes,
only thing what I just wanted to know from you
yes,
is,
sir.
in your practice these days, when a child is brought for respiratory symptoms, not that each and every child can afford, the nasopharyngeal swab, or, he may not afford the respiratory panel for viruses or bacteria, and we have to have our own clinical judgment. So, just as in the beginning, I said a little bit about the clinical differences between viruses and bacteria. In your practice, what are the guiding principles which guide you to take a decision whether this child really requires antibiotics, whether he really requires antivirals, and whether he requires both together? So maybe you can just highlight some of these points, which you probably follow in your practice.
Yes, sir. So basically, if we are seeing a patient with in this season or with some cough, cold, fever, then if there is a clear-cut bacterial localization, like there is sore throat, tonsillitis, or something which needs antibiotic, then we may start antibiotic early. But if there is only cough, cold, fever, and we are not able to just means judge whether it is bacterial, or then we can also look for the toxicity of the patient. If the patient is very sick, toxic patient, and not improving, maybe after 48 to 72 hours, then maybe we can consider for bacterial infection, and we can go for some basic blood investigation like CBC, where CRP also may help. And if they are suggesting any bacterial infection like thing, we can go ahead with antibiotics. And if it is not, then we may think of viral also. And if there are some, as I always say, if there are some atypical features that the patient, even if after starting antibiotic, if the patient is not responding the way he should respond, that is one thing. And if the patient is drowsy or patient is excessive sleeping, then we should think of especially H1N1. Then, because in practice we have seen that those patients who are becoming drowsy, excessive sleepiness, we have, for few patients we have sent the swabs also, and they have come positive for H1N1. So in the patient who is drowsy and excessive sleepiness, we should be more, either we should send swab, and if the patient is absolutely not affording and we want to start treatment, then we can go for the oseltamivir directly also. In some cases, it may be justified. And as you said, if the patient is deteriorating, then you should go for oseltamivir, so that otherwise he will go into ARDS like things.
Yes.
And other high risk patients like means we see allergy asthma patients. So if the patient is having allergy asthma, then there are more chances that they will get more symptoms of this any flu like symptoms. So actually those patients, they are mainly, we are advising them vaccination, because they should not get this flu symptoms only. So generally, ideally it should be given to all, but especially high risk patient or allergy asthma patient, immunocompromised patient, then we should stress them to take vaccination also. And this patient, we should keep a critical watch on them.
Correct. Yes, you're right. And just wanted to know one more thing, that suppose if there is a child who comes to you little late in the course of any respiratory illness, like say comes not on first or second or third day, but comes after say 5, 6, 7 days, and really at this stage he is bad. But then many times, along with your colleagues, you are managing, say for example, in an institute, then even at this stage, uh, simply on the clinical suspicion, do you think that oseltamivir is of use even when given little late in the course?
Yes, sir. Ideally, it should be started within 48 to 72 hours. But even if it is late and if you are strongly suspecting it, patient is not improving, there is some high risk point. There are some, when you say we are thinking that it may be viral, there is no harm in starting the treatment. Even if it is late, it will help. May not be as it has started for within 48 hours, but definitely we should give the benefit of doubt to the patient.
Right. So I also agree with you because it reduces the mortality. Even if it is started late, it does have some advantages. And one important thing is that as I was talking in my presentation about H1N1 and H3N2 during the last year and this year, now H3N2 has started rather becoming more important. And the severity of the illness from different centers has shown that H3N2 is the one which is supposed to be much more serious as compared to H1N1. And of course, that is definitely there in the vaccine. So the vaccine does include both the type A viruses, H1N1, H3N2, as well as Victoria and the Yamagata strains of the type B, the lineages. So that is really very, very important. Is there anything else that you would like to mention to our listeners from your side?
Just your means you have already covered everything. So just highlights of your lecture only that as I said, ki drowsy sleepy patient we should keep a watch, and allergy asthma patient we should keep a watch. We should always look for whether this patient is going into respiratory failure or not. So that is a very important thing. And definitely early starting, it is a right means we should start it rightly, means not overuse or not underuse. That is the most important thing, and that is definitely pediatrician judgment. We have to do it. And so if you start it on the right time, definitely it will reduce the complication. It will reduce the hospital stay also. And as I said, vaccination should be recommended to most all the patients, but high risk they should be stressed on. That's also.
Right, right. Thank you very much. So, it is very nice that you have given these important inputs. And I always say that it is necessary that you vaccinate against flu and take care against flu by all those cough etiquettes and other things. Because in the word FLU, flu, it ends with U. So, it is all up to the parents and physicians to advocate. And one more principle which I follow even for adults also, like and even for physicians, that every birthday we always say that happy birthday to you, but I say it is happy birthday to flu. Okay, so it is because every year one has to take that annual influenza shot. So which is the better day than the birthday when you should take the flu shot, because then at least you will remember that on every birthday you must take the annual flu shot. Now, my birthday falls in the month of August only, so it is always a rainy season. And that's why I make it a point to take annual flu shot on 10th of August, which is my birthday. Anyway, so the point is that one has to be, very, very much aware about the preventive measures, because once the influenza infection occurs, it really, drains all the energy. The person is unwell and unsick for 3, 4, 5, 6, 7 days, and many of us have these days lifestyle diseases, the even the adolescents who are obese, and the adolescents who are many times having respiratory problems. I'm sure you must be seeing it in your practice also. So there are various problems in the community related to the children, to the adolescents, adults, elderly, and influenza is the one where we must be very, very careful as far as the prevention and therapy is concerned. So with that, we will just, conclude this particular discussion, and I hand over to Mrs. Samruddhi for her concluding remarks.
Sir, we have certain questions
Yes,
from the participants.
yes,
First question is from Dr. Kiran Vanarse.
yes,
Why should we start Fluvir without blood investigation? I mean, this had come at the beginning of the webinar.
yes,
So the question is, why should we start Fluvir without blood investigation?
yes. Now, first, I will tell my viewpoint. Remember that whenever a child with influenza comes, the usual, that means a suspected case of influenza, as I said in the beginning, whenever a child comes, and suppose if you have the facility of doing the complete blood count, Then remember, the typical blood picture of influenza has been that it is basically a viral illness. So we know that there is, not much of, WBC count rise which is going to occur. But lymphopenia is one of the important features of some of these viruses. Just as, in case of COVID also, we found the, influenza itself can have very, very low count of lymphocytes. So we should take it as an important marker. Secondly, by the time many times people get the reports, and when they come to us, they may take another 24 48 hours. And the reason that I told you, that before 48 hours, already the patient might come to a consultant after 3 or 4 days, because usually he may take a treatment from a general physician. And that is why, if you take it early, that means if you give the therapy early, nothing is lost. And the child, but entire thing depends on your clinical suspicion. As I told you, headache, myalgia, weakness in a flu season is something which you must keep it at the back of mind. Not that every child coming with sneezing and runny nose and all, we are going to give oseltamivir. And then that is the reason one should give it in the beginning of the illness. But in case if you have some supporting blood reports, well and good, because I can understand that the nasopharyngeal swab is not something which is going to be available at each and every place. And Dr. Sainath, you have any inputs on this?
No, sir. No, sir. Yes, absolutely. Yes.
Okay. Then I can see in the chat box.
Yeah.
Similar question from
Similar question. Yeah.
saying whether it is taken before the blood report. As I said just now, the blood report or the nasopharyngeal swab, they will definitely aid you in the therapy. See, it happens so many times. I will tell you, a child comes to us with fever, cough, and cold. He is okay for 1 or 2 or 3 days, but the fever doesn't go down. Okay, the day 4 and day 5 comes. Now, if you see practically, all those who are running hospitals, or those who are having their own indoor practice, they are bound to now send the investigations, take an X-ray, and also start with ceftriaxone. Okay. Now, during the last year and even during this year, it has so happened that after 4, 5, 6 days, the fever is not going down. The ceftriaxone is given, but the child is not responding at all. Now here, when you have the facility of doing the blood count or the nasopharyngeal swab, then you are definitely guided properly. So in quite a few cases, we got adenovirus when we did the throat examination for the nasopharyngeal swab, and that guided us, and told us that it is not ceftriaxone which is necessary at this moment, but probably nothing is necessary. However, adenoviral infections are a bit different. There, the fever continues for a long time, even it can continue up to 2 weeks, and there could be additional features also. Similarly, at this juncture, if you get H1N1 positivity, then you are always going to start oseltamivir without any problem. So it guides you. So nasopharyngeal swab does guide you. However, the blood report, as I told you, some changes in the blood count, particularly lymphopenia, along with the nasopharyngeal swab, they will definitely guide you. But some of these viruses are very deceptive, and many times lobar pneumonia, for example. Now we have been classically saying that lobar pneumonia means it is pneumococcal pneumonia, that is Streptococcus pneumoniae. But even adenovirus produces this particular type of round pneumonia, so to say. So we have to be very careful about these viruses. And the days have started coming, where it is quite likely that we will be able to pinpoint each and every virus. Of course, India is little far off from this situation, but then over a period, it is quite likely that we will be able to, tell the parents that, see, your child has influenza, your child has croup, so he has probably para-influenza. Not only the clinical, but even the laboratory also. And then, of course, one of our colleagues has asked as to how long we use. We have already said that for therapy, we use it for 5 days, and for prophylaxis for 10 days. And then we have also clarified certain things about the age criteria. Between the age of 0 to 3 months, we have told about the therapy, but below the age of 3 months, we have said that it is not to be given for prophylaxis. These are some of the points which we have already clarified in the presentation. So I hope most of the points are clear. And Mrs. Samruddhi, in case if there is something else which you would like us to clarify, please let us know.
Thank you, sir. Most of the questions are covered, and therefore I really thank you on behalf of Hetero Healthcare, and I thank Dr. Sainath Pawar also and Dr. Pramod Jog also for being with us, sir. Thank you, sir. Good day.
Thank you, madam. Yes.
Thank you very much.
Thank you.